Okay, we're going to take a quick look at chapter 16. It starts with PTSD in children, but we're actually just going to move forward and move to trauma-related disorders in adults because our main focus in this class is adults. Okay, so our first topic here is trauma-related disorders in adults. And the main one that we're going to be looking at right now is post-traumatic stress disorder. I think many of us are pretty familiar with what this disorder is, and we hear about it a lot, especially related to military service. But I do think that we have to remember that it goes hand in hand with a lot of other traumas that people experience. Really, it's anything that involves either an actual or a threatened death or serious injury to their self or others. So just experiencing that, usually they're having a sense of fear, helplessness, and just really being frightened during the traumatic situation or event. And what you see when our patients have PTSD is many times they re-experience the trauma, and then they're going to avoid those triggers that cause them to re-experience that trauma. They kind of just relive it again. They do have a lot of issues with being overly aware of their surroundings, and that can really alter how they're feeling because that sets them kind of on edge to experience anxiety, and it might stem more to a fear situation or anger. We do tend to see PTSD together with other mental health disorders like depression, anxiety, sleep, and even dissociative disorders, and we'll get to those here in a little bit. Many of our individuals with PTSD are usually feeling pretty sad, maybe angry, even guilty for being part of the previous experience that they didn't have any control over. Some other things related to PTSD that we want to think about is we want to make sure and help them to address their maladaptive coping or that maladaptive response that they have to the trauma. So they're going to be working with a therapist that may look at both the behavior side and really talking through the stress that happened in their life. So they're going to teach them some strategies like deep breathing, mindfulness exercises. Those are pretty simple ones to teach. They may need some more intense therapy related to the trauma that they experienced, but that's going to help some. Some of our patients will go on medications. There are 2 FDA-approved drugs right now, Zoloft and Paxil. There are some other medications that we give, but they do tend to have higher side effects. And I'm sure you guys have already listened to the ATI, Pharm Made Easy, and so make sure and listen to that if you haven't. Adjustment disorder, a lot of times we think about that in relationship to children rather than adults, but it is important to remember that adults also will have adjustment disorder, and usually it's precipitated by a stressful event. However, the event could be something that seems positive. It may not be as severe as what they might experience with a traumatic event as related to PTSD, but it does cause a debilitating cognitive, emotional, behavioral symptoms that do negatively impact their ADLs. Their quality of life scores tend to be higher than with those with major depression, but lower than the normal average person. And so their response to stress could include depression, but it also tends to include depression and anxiety, and sometimes some other conduct disorders. So with these different disorders, we have to look at the comorbidities that go along with them. We tend to see anxiety and depression along with those. We do want to make sure that they get in and get some treatment and get some help with some coping mechanisms for either of the 2 disorders that we've already talked about. We do see that the prevalence of this adjustment disorder does vary widely. It does depend on where the setting was for the study. So if we looked at people who were hospitalized, that's going to happen more often than in maybe a primary care setting where it's just people coming in for well visits and that type of thing. The biggest kind of hot topic in this chapter is dissociative disorders. This is a kind of different disorder that maybe you've never even heard of before. But dissociative disorders usually happen when they have really high stress, really high anxiety, and it's their body's way to kind of shut down and escape from the current situation. And so it actually kind of interrupts the consciousness with their environment that they're experiencing. So a lot of times it's protecting the patient from their overwhelming anxiety. So with this emotional separation, they are not anymore experiencing the anxiety that they were. A lot of times we think about a disassociation as, something big and profound, but also many of us have experienced disassociations in our own life. The example that I use many times is when you're driving down the road and maybe it's a path that you're really familiar with. You drive maybe from school all the way home, and then you get home and you're like, oh my goodness, I don't remember any of my drive. How did I get here? So that's kind of an example of what a disassociation is like. So it breaks it down into three main topics here. Depersonalization/derealization, and then dissociative amnesia and dissociative identity disorder, which is the one we're more familiar with. So depersonalization is the focus on oneself. So really, you almost become an observer of yourself rather than experiencing the environment on your own. You're kind of watching yourself experience it. Derealization is focusing on the outside world. So it's almost like a feeling that the environment around you is not real, that you're just kind of going through the motions in this kind of real, unreal, or distant type of a world. It might feel kind of robotic to the patient. And these are all ways that a patient is going to help disassociate from the anxiety they're experiencing. Dissociative amnesia is the inability to recall important personal information after trauma or stress. A lot of times we see this with violence. We were just talking in acute complex about head traumas, and it's really difficult in a couple populations to know if there's a head trauma involved or if it might be something else. The two populations that we have a big struggle with are those that maybe are abusing substance at the time of the trauma, and secondly, if their trauma was around a violent criminal act. Many times they have difficulty telling us what's going on because they just have blocked that information out. And so a lot of times dissociative amnesia is localized. They're just unable to remember all of the events around that certain period, or it could be selective. They just remember certain parts of it. There is a subtype of dissociative amnesia that's kind of interesting, and it's called dissociative fugue. And it's where the patient actually travels to another place and they have no idea who they are. Maybe you've seen this on the news before, but in the fugue states, they function adequately within this new identity, but they don't typically remember who they are during that time. It may take a few weeks to a few months for them to remember their former identity, and then maybe get back to kind of their normal life. What's kind of really frustrating or difficult about a patient with that is that they're very distrusting of others. And you can imagine if you're not really sure with who you are, how you're not going to trust others, especially if they're telling you, no, you're so-and-so, or we don't know who you are. So that trust becomes a real difficult rapport to build with that patient. Dissociative identity disorder, this is previously known as multiple personalities. And a lot of times we look at our patients with dissociative identity disorder as having at least two other identities, one as a person who functions on that daily basis, and then another that is kind of that protective personality that's protecting them from the anxiety that they're experiencing. Each alter is really complex, has its own memories, own behaviors. If anybody has seen the movie Split, or if you have watched the new movie out in the theaters, Glass, we see the individual there that has 23 different alters or personalities, and that's extreme. We usually only see two. If this disorder happens, it's actually pretty rare that anybody has dissociative identity disorder, but it definitely makes for good movies. And when somebody experiences this in their life, it can really damage relationships with their family and their friends, because this other person that they're becoming, kind of has their own agenda. So sometimes we might look at, do they come home? Are there different clothes hanging in the closet than they remember purchasing, or something like that for dissociative identity disorder? So our dissociative identity disorders, we look at a lot of different things that happen in their life. We do see a lifetime prevalence of dissociative disorders from 2 to 10%. Depersonalization, derealization is about 2, dissociative amnesia 2 to 7, and dissociative identity is usually around 1.5%. And so that's kind of interesting. The comorbidities, we do see it, of course, with any type of our anxiety disorders, but also sometimes major depression. And so even personality disorders like borderline, we see it happening with those. So some risk factors would be childhood trauma. Dissociative symptoms are more of like a mind flight. So you're reducing the anxious feelings by disassociating from yourself. Genetically, we do see some variabilities that are thought to play a role in stress reactivity, because we know that disassociation is basically due to that extreme stress. Neurobiological, we look towards the limbic system. Psychological factors, we look at the ego defense mechanism there as really just yourself kind of protecting itself. Environmental, dissociative disorders are a response to overwhelming trauma and the environmental factors as well. So that's kind of what we see with our environmental factors, like traumatic events, car accidents, being deployed in the military, being in combat, even just neglect and those types of things too. And there are some cultural considerations to think about too, and you guys can take the chance to read over those. Okay, so we already kind of talked through these: depersonalization and derealization. Depersonalization is the focus on self, kind of like you're watching yourself. Derealization is feeling kind of like you're going through a different world. And we know dissociative amnesia is the inability to recall important personal information after a traumatic or stressful situation. And if they travel away from their home environment to another place to live, that's called dissociative fugue. And you might hear someone call it a fugue state, where the fugue means that travel away. Dissociative identity disorder, I think that we have already discussed all the way through this one as well. But if you have any questions, please let me know. So whenever we look at the assessment for our patients with dissociative disorders, and that's any of them, we have to look at the history, looking at their life events. There's some questions here that say, have you ever found yourself wearing clothes you cannot remember buying? And if you think to which one of those that goes back to, that would be our dissociative identity disorder. Have you ever had strange persons greet you and talk to you as if they were old friends? Does your ability to engage in things such as athletic, artistic activities, and mechanical tasks seem to change? And so some of these relate specifically to a disorder, while others are just looking at the overall idea of what's going on, especially memory. Can you remember the recent and past events? That's going to look at dissociative amnesia. Is the patient's memory clear or incomplete, or is it partial and fuzzy? So as you look through some of these questions, be thinking about which of the disorders they would link back to. Suicide risk is really important to assess because this patient's life has really been disrupted. And so we do need to assess for that. And remember, with suicide risk, we're going to assess that point blank. Are you feeling suicidal or like harming yourself? And so those are really important questions to ask. The self-assessment is looking at yourself as the nurse, because it could be uncomfortable when you're working with people who have really lost an awareness of themselves. That can really play a pretty big role or on the nurse. And so you want to make sure that you're kind of looking at how you're feeling, because this doesn't seem real, especially when someone goes into like a dissociative identity disorder. You feel like you may be being manipulated. So you want to make sure that you're looking at those feelings as well. One of the things that I want to point you to, and this is in every chapter, the bottom of page 310, table 16.1, those are the signs and symptoms, nursing diagnosis, and outcomes for the dissociative disorders. Every chapter has a table that looks like this for the disorders within it. And I think that it's really helpful to just generalize what is going on with each disorder. And it may be really helpful for differentiating the disorders for you. So whenever we look at a patient and work with a patient with any of our dissociative disorders, we do have to look at how we would implement the interventions. For psychoeducation, we usually have to learn, we usually have to teach our patients a lot about their illness and teaching more coping skills and stress management to help them not disassociate. A lot of times we'll teach grounding techniques. This may be a stomp of the foot, taking a shower. Usually it's something that's kind of extreme, maybe holding an ice cube. They even talk about just deep breathing that will help calm the anxiety, will help ground them as well. Journaling also tends to be pretty helpful. We suggest that they journal for about 10 to 15 minutes each day. No specific pharmacological interventions are there for dissociative disorders, but we do have to really look at the comorbid disorders that go along with it, the depression, the anxiety. They might need something for their anxiety, especially also depression if they're experiencing that. Advanced practice interventions, we're not going to talk too much about those. I really do like the bottom of page 311, the table that's down there too, that provides interventions that we use for dissociative disorders with the rationale. At the end of each chapter, it does have our key points to remember, so those are also nice to look over. And then some practice questions to help you kind of focus in on the information. The answers are available right at the bottom. Okay, we've got one practice question with this set of slides. So a nurse assesses a patient diagnosed with dissociative identity disorder. Which finding would likely be part of the patient's history? So is it A, travel to a foreign country, B, physical or sexual abuse, C, thyroid dysfunction, or D, eating disorder? And remember, when we're looking at the patient's history, we're looking at something that might trigger the event. So A, travel to a foreign country, actually is more of a description of dissociative fugue. B, physical or sexual abuse could definitely be in the history of our patient with dissociative identity disorder. It's that traumatic experience. C, thyroid dysfunction. The thyroid does tend to mimic some of our disorders, our mental health illnesses, many times like anxiety or depression, but not one of our dissociative disorders, and especially not dissociative identity. And then an eating disorder, which is D, is something that could happen along with it, but it's not typically part of the history. If you guys have any questions about this chapter, please let me know.